Hi, my name is Jonathan Routh. I'm a faculty member in the Division of Urology here at the Department of Surgery at Duke University Medical Center, and today I'll be talking to you about the contemporary management of pediatric genitourinary tumors. I'll be going over briefly some of the workup and treatment for GU tumors, primarily renal tumors, but also tumors of the bladder, retroperitoneum, testis, that type of thing, and also go over some of the current controversies in the management of those tumors. Use of biomarkers and other prognostic factors that can influence the management of these children. For example, for a child with a renal tumor, should we use a partial or radical nephrectomy to treat that? And also, should we be using an open or a laparoscopic technique? Personally, when I think about kids with tumors, I tend to remember things best when I think about the individual children that I'm seeing, not necessarily the disease itself. So I'd like to go over with you today some of these individual children that I've seen over the past few years. I'd like to start with a 6-week-old female who presented to me with an abdominal mass. This is a product of a normal pregnancy and delivery, ridiculously cute little child. She came in with a pulse of 120, blood pressure very, very high for a 6-week-old at 150/87. Respiratory rate was normal for a baby at about 30. And on abdominal exam, although she was non-tender and non-distended, there was a very clear, firm left upper quadrant mass. And here you can see a picture of that with the mass actually deviating everything off to the left side of her belly. So the questions in my mind at this point are, what's my differential diagnosis and what further workup do I want to do as I'm seeing this child? So anytime that you see a child for the first time with a possible renal tumor, on physical exam, things you want to pay attention to are, does the child have normal eyes? Is there aniridia or absence of the iris? Is there a genitourinary anomaly like hypospadias that's present as well? Do they have hemihypertrophy? Do they have a very large tongue? Do they have a varicocele, particularly on the right side in boys? And also, what's their blood pressure? Labs that may be helpful is checking a CBC. Up to 8% of children with a Wilms tumor can have a von Willebrand's type of deficiency. Electrolyte abnormalities are relatively common, with hypercalcemia and renal failure occasionally being present. We also want to check for liver function tests and a urine analysis to see if there's any blood in the urine as well. On imaging, things to think about is to begin with an ultrasound and make sure that this isn't just a child who's really constipated. If indeed that does show an abnormality, we can then proceed with a CT scan or possibly sometimes an MRI as well. One of the key things that you want to determine here is, does this a child have a solid tumor or a cystic tumor? And we also want to exclude lymph node or vascular involvement of the tumor. Oops. So in this child, we actually began with a KUB or a flat plate abdominal film of the belly, and you can see here that the entire abdominal contents are shifted over to the right to make room for this very large tumor on the left side. And on CT scan, you can see that indeed this is a pretty big tumor for a pretty small baby. So the management of this will be an open radical nephrectomy in a child this size, particularly in a tumor this size in a child this size. And our final diagnosis here was what's called a congenital mesoblastic nephroma, which is a typically benign tumor of the kidney. This is what it looked like underneath the microscope, and you can see the characteristic signs of a congenital mesoblastic nephroma. And I'd like to review for you for a moment just what the broad differential is by age, because that's a convenient way of, and a helpful way, I think, to think about what the determining diagnosis is going to be in these children. Between 0 and 3 years of age, Wilms tumor and congenital mesoblastic nephroma are the most common things. Other less common tumors can be a clear cell sarcoma of the kidney or a rhabdoid tumor of the kidney. And in this child, obviously, this was a congenital mesoblastic nephroma that was present. So a quick word on mesoblastic nephromas in general. In infants, these are by far the most common renal tumors. The median age at diagnosis is about 19 days, and about 90% of these are diagnosed within the first year of life. These are virtually unheard of after age 3 years. In medicine, you never get to say never, and you never get to say always, but in general, these tend to be diagnosed in the first year or so of life. Male to female ratio is typically 2 to 1. These may be associated with polyhydramnios, so too much fluid in the amniotic sac during pregnancy. And they may actually be found on fetal imaging. In fact, my partner and I recently operated on a small baby that was originally noted at about 34 weeks of gestation. These have an excellent prognosis. These children generally tend to do very, very well, and radical nephrectomy or complete removal of the kidney is generally curative in these children. There is a variant of these tumors called a cellular variant, and in fact that's what this particular child had. And in more advanced stages of mesoblastic nephromas can occasionally benefit from chemotherapy. Luckily in the baby that I mentioned here, we did not need to go down that route because she's done very well since then. So I'd like to move along to a second case. This is a nearly 2-year-old little boy who came in with blood in his urine, or gross hematuria. On past medical history, he was otherwise very healthy. His pulse was about 115, fairly normal for a kid his age. Blood pressure mildly elevated a little bit on the systolic at 117/51. He's breathing pretty normally for a kid who's running around the office and otherwise feeling happy at about 32 times per minute. An abdominal exam, non-tender, non-distended, and no palpable masses whatsoever. But on imaging exam, we did obtain a renal ultrasound because of the history of blood in his urine, and on that we found a complex cystic renal mass. And again, the questions I think to myself are, what's my differential diagnosis, and what further workup imaging test do I want to perform? So on ultrasound here, you can see his right kidney, the top part of the right kidney does have this very odd appearing cystic or very complex renal mass. And on CT scan, you can see there's actually what appears now to be a solid tumor that's actually completely taken over the upper part of this right kidney. Our management for this boy was an open radical nephrectomy, and our final diagnosis was a favorable histology Wilms tumor. In fact, because this was a relatively small tumor, he fell into a very low-risk subgroup. Wilms tumor, again, is going to be the most common type of tumor between ages 0 and 3 years. Again, other possibilities in this age range: congenital mesoblasttic nephroma, clear cell sarcoma of the kidney, and rhabdoid tumor of the kidney also distinctly possible. Wilms tumor is the most common primary renal tumor in children. It constitutes about 6 to 7% of all childhood cancers, and the annual incidence is about 500 cases in the United States. Median age at the time of diagnosis is about 3.5 years old, but there's a fairly wide band of diagnosis age around that. And about 5% of these tumors will be bilateral and occur in both kidneys at the same time. Overall survival for children with Wilms tumor is excellent, about 92% of all comers, and about 98 to 99% of all children with a stage 1 tumor like this little boy had will actually do very well long term. There are certain syndromes that are associated with the diagnosis of Wilms tumor. The most common one is what's called the WT1 gene. It's located on the 11th chromosome, the P13 portion of that chromosome. There's two syndromes that are predominantly associated with the WT1 gene. The first is the Denny-Drash syndrome, and that's associated with a disorder of sex development, renal mesangiosclerosis or renal failure, and the development of Wilms tumor. Those children will typically have ambiguous genitalia or hypospadia, some other type of abnormality present as well. The second is the Wager anomaly, which is Wilms tumor, aniridia, or again the absence of the iris, gonadoblastoma, which is a specific type of tumor that can occur in underdeveloped streak gonads or testicles, and severe developmental delay. The WT2 gene, which is also associated on the 11p chromosome, this time on the 16 portion of that chromosome, is also associated with several syndromes, and the most common of these is what's called the Beckwith-Wiedemann syndrome. The hallmarks of Beckwith-Wiedemann syndrome are macroglossia, or an overly enlarged tongue, an overgrowth syndrome where typically, again, hemihypertrophy or overgrowth of the leg, of the arm, of the kidney, that type of thing, omphalocele or another midline defect. And these children also have a 10 to 20% tumor risk, either with Wilms tumor developing in the kidney or hepatoblastoma as well, developing in the liver is another possibility. There are also several other overgrowth syndromes that are associated with this. Abnormalities of chromosome 1p, of 16q, and of 7p have been reported. Overgrowth syndromes such as Perelman syndrome or isolated hemihypertrophy, where one arm or one leg, generally speaking, is going to be much larger than the other. And as well, mullary duct abnormalities and horseshoe kidneys are associated with the development of Wilms tumors. Importantly, because these children have such a great long-term survival, we have to think about what the long-term effects are of the treatments we give to these children in order to give them a cure. Secondary neoplasms, or a second cancer that develops after treatment, can develop in a little under 2% of these children, about 1.2% risk long-term. For children who get a particular drug called doxorubicin, there can be a risk long-term of congestive heart failure. And as well, it's very important to consider endocrine failure and infertility in these children. The field of oncofertility, if you will, is founded on this. In males, there's about a 63% risk of oligospermia, or a decreased sperm count. And in females, there's about a 12% risk of ovarian failure, and that's particularly worse if they've received a large amount of chemotherapy or if they've received radiation therapy as well. Renal insufficiency, importantly, can happen in these children. As you can imagine, if you're removing one kidney, they only now have one to get by on for the rest of their days on Earth. And renal failure occurs in about 2% of children at about 15 to 20 years of follow-up who have undergone unilateral resection or one-sided resection of Wilms tumor. In children that have kidney tumors that come up on both sides, the renal failure rate is about 10%, so significantly higher, and it's even further increased in children with Wilms tumor syndrome, particularly the Denny-Drash syndrome that I mentioned earlier. Which brings up those controversies I mentioned before. So in order to reduce the late effects of chemotherapy and radiation, ideally we need to be able to risk stratify children, so to determine what children are going to have a lower risk of recurrence or a higher risk of recurrence. And one of the ways that we can do that is by developing better biomarkers or better prognostic tests that will tell us whether or not a child is likely to recur. And in order to prevent renal failure, one possible option is to perform something called a partial nephrectomy, or removal of just part of the kidney, just the part that's affected by the tumor itself. In terms of current biomarker research, we know that overall children with Wilms tumor generally tend to do very, very well. However, up to 15% of kids with one-sided Wilms tumors can actually have a recurrence, or after the tumor is treated, that tumor can come back. And so we know that our current prognostic models, our risk prediction models, are slightly imperfect. And this essentially comes down to a balancing act. We're trying to balance the risk of recurrence from the risk of treating them too much and getting too much by way of a late tumor effect. One of the ways that we're working on that currently is to look at genetic biomarkers, and in fact those have been incorporated in the current group trial designs for children who have Wilms tumor. Specifically something called loss of heterozygosity. It's a specific genetic defect that can occur at chromosome 1p or 16q. And it turns out that if children have those markers that are present, they will actually get more treatment, more chemotherapy, more radiation, etc. Other biomarkers are currently under development, including some that we're working on in our lab here at Duke, such as immune modulators or growth factors as well. The best biomarkers are currently unknown, and this is an area which is quite ripe for future research and future development, again, some of which is undergoing here at Duke. A second controversy is the use of partial nephrectomy in children with Wilms tumor. We know that in adult renal cancer, partial nephrectomy is a well-established treatment that's been around since the 1980s. But in children, there's a relatively limited use of this, and there's a good reason for that. In general, children with Wilms tumor tend to have very big tumors and a very little body, and as such, it's very technically complicated to try to remove just the affected part of the kidney and leave a remaining functional kidney unit behind. However, there's an emerging literature that supports the use of partial nephrectomy in very well-selected children. In fact, the Children's Oncology Group currently has a protocol called the Areno 534 protocol that's specifically for the use of partial nephrectomy in children with bilateral or very high-risk unilateral tumors. Again, those who have a syndromic tumor like Becker-Lehman syndrome, like Denny-Drash syndrome, that type of thing. What we know is that about 2% of children with Wilms tumor, again, will progress on to end-stage renal failure later on in life. Because of those higher risks for the syndromic and the GU patients, that's why the Children's Oncology Group is currently studying this. But we also know that up to 25% of children may be amenable to partial nephrectomy. And we also know that partial and radical nephrectomy do appear to have similar outcomes, and again, in very well-selected patients. Usually those are the very small tumor that's located at the very top or the very bottom of the kidney. The potential benefits of partial nephrectomy are a lower risk of chronic kidney disease and end-stage renal disease later in life. Potential harms is if we're not taking an adequate specimen and an adequate removal of the kidney, we may be predisposing those children to an incomplete resection or to a higher risk of relapse down the road. Bottom line, partial nephrectomy is best used in a trial, but we're actively pursuing and hopefully we'll be achieving a trial of partial nephrectomy and radical nephrectomy use through a larger group design in the near future. This highlights, I think, the importance of the team because both partial and radical nephrectomy are very technically challenging procedures. And there is no such thing as an easy Wilms tumor. Here at Duke, we perform all kidney tumor surgeries together jointly. In fact, virtually all cancer surgeries are done jointly with myself on the pediatric urology end of things, and either Henry Rice, Lisa Tracy, or Bennett Debe on the pediatric surgery end of things. That way there's two fellowship-trained academic surgeons operating together to make sure that that child in front of us gets the best possible care in the best possible way all the time. All renal tumors here at Duke are managed by a multidisciplinary tumor board, and we get involvement from not only our colleagues in pediatric oncology, radiation oncology, myself in urology, pediatric general surgery, and also pathology and radiology as well. So enough about Wilms tumor. Let's talk again about another little boy this time. This is a 2-year-old male who came into me with a newly discovered abdominal mass. He was playing on the playground. fell over and his teacher picked him up and noticed that he had a little bit of a firm belly. This is an otherwise healthy little boy with no significant medical problems in the past. Again, on physical exam, he's completely normal, but he does have a left upper quadrant mass that's present. And here you can again see his abdomen being pushed to the side in order to make room for this tumor on the left side. The questions again in my mind are, what am I looking at and what further workup do I need to do? On CT scan, you can see here a tumor on the left kidney that has essentially completely taken over the entire left kidney and replaced most of the normal architecture. And again, this is not a child that we felt would be amenable to a partial nephrectomy, so we performed a radical nephrectomy instead. And what we discovered was this was what we call a clear cell sarcoma of the kidney, which is generally a more rare type of tumor. This is what it looks like underneath the microscope with a classic sarcoma type architecture. And again, this is one of the less common types of kidney tumors that can occur, but it clearly is well within the differential, especially in that 0 to 3 year age range for children with solid renal tumors. So clear cell sarcoma of the kidney constitutes about 3% of all pediatric renal tumors in the United States. The median age at the time of diagnosis is 2 years, spot on with this little boy, and there's about a 2 to 1 male to female ratio. What we know is that metastatic lesions with clear cell sarcoma of the kidney are very common. In fact, an older name of clear cell sarcoma of the kidney is actually the bone metastasizing tumor of the kidney. It typically will go to bone, and so a bone scan is indicated in all of these patients. It can also metastasize to lymph nodes, to the lung, or to the liver. The 8-year overall survival for all comers with clear cell sarcoma of the kidney is about 83%, so markedly lower than you would expect with Wilms tumor. But luckily, those with a stage 1 or stage 2 tumor will still actually do fairly well, with about a 95% or better prognosis long term. However, this is highly dependent upon age and stage. Higher stage tumors, stage 3, stage 4, do not tend to do as well. And we also know that there's a lower survival among infants and among children greater than 4 years old. So for the very, very young and the relatively very old children, those kids with clear cell sarcoma do not tend to do as well. Lastly, another possibility is what's called a rhabdoid tumor of the kidney. I won't dwell too much on that, but suffice to say that it is present in about 2% of all renal tumors. The median age of diagnosis is a little younger than Wilms tumor or clear cell sarcoma, between usually about 11 to 13 months, so right around 1 year of age. The ranges for which it's been reported are between 1 month and 5 years of age, and there's a slight male predominance, about 1.4 to 1. This is what it looks like under a microscope, and this is what it looks like in a CT scan. You can tell here overall that this is a relatively aggressive tumor. 29% of these patients will present with metastatic disease. This commonly present with hematuria. There is a predilection for central nervous system involvement, and it's difficult to tease out sometimes in these children with rhabdoid tumor is that a kidney tumor that's metastasized to the brain, a brain tumor that's metastasized to the kidney, or a concurrent primary. So 2 primary tumors, one occurring in the kidney and one occurring in the brain. Any of those possibilities can occur, and the long-term survival for those children is markedly less, about 23% at 5 years. So on to happier topics. Case 4 is a 14-month-old female who is noted incidentally to have a kidney mass. She's otherwise healthy. Her pulse is 110, blood pressure fairly normal, 120/67, maybe a little high. And on ear, nose, and throat exam, a very astute pediatrician noted that this child had macroglossia, or a slightly enlarged tongue. An abdominal exam, non-tender, non-distended, no palpable masses. But this child actually was receiving regular renal ultrasounds, again, because of that big tongue and the very good pickup by her pediatrician. She was noted to, and ultimately developed, or diagnosed, I should say, with having Beckwith-Wiedemann syndrome, as I mentioned earlier. Because of that, she was put on a regular imaging regimen where every 2 months she was getting an abdominal ultrasound to look at the liver and look at the kidneys to make sure that those were developing well. And on one of those screening ultrasounds, she was actually noted to have a solid tumor. Again, in this situation, the differential diagnosis is somewhat more limited, but we do need to worry about the further workup. So on ultrasound here, you can see on the upper left side of her tumor, on the upper left side of her kidney, a small tumor. And on CT scan, you can see the small tumor popping itself out from the bottom portion of her left kidney. Management in these children, again, because of the fact that she does have a syndrome which predisposes her to a high risk or high risk of recurrence, she actually received neoadjuvant chemotherapy per the COG trial that I mentioned before, RENO 534. She then underwent a partial nephrectomy, and then after 6 weeks of initial chemotherapy, upfront surgery, she then completed her chemotherapy course. and her final diagnosis was a favorable histology Wilms tumor. So here you can see what she looked like after the tumor was removed. There's a very normal-looking right kidney and a very normal-looking left kidney where you can barely even tell that we did anything at all. Case 5 is a 16-year-old little girl who came in to see us with blood in the urine. Interestingly, she did have a history of acute lymphocytic leukemia as a young girl. About age 2 is when that was diagnosed. She'd done very well for the following 14 years. And now coming back in with blood in the urine, as you can well imagine, the family was pretty concerned about that. Pulse 78, blood pressure slightly up, 130/67, respiratory rate of 20. In abdominal exam, you can feel a right upper quadrant mass that is clearly present. Again, now we're wondering about a teenager, so that changes the differential diagnosis just a bit from what we discussed before. And the question then becomes, what do we do in terms of further workup? So here you can see on her scan a very large mass that was present within the right kidney. And for this child, we actually chose to pursue a laparoscopic radical nephrectomy, which is a bit of a change from what we discussed before. And on final diagnosis, this wound up being what's called a translocation or renal cell carcinoma. So let's go back to our list of tumors by age. We've discussed before 0 to 3 years somewhat exhaustively, but between 3 and 10 years, the list narrows down a bit. Wilms tumor and translocation or renal cell carcinoma in adolescence becomes much more common here. And at about 10 years, there actually is a shift where Wilms tumor becomes less common and translocation or renal cell carcinoma actually becomes more common. In general, if you're seeing a child with a kidney tumor before age 10 years, renal cell carcinoma is going to be less common than Wilms tumor. Wilms tumor is by far the more common. Between about 10 and 15 years of age, they're roughly equivalent, and so you're just as likely to have a child with renal cell carcinoma or translocation carcinoma as you are a child with Wilms tumor. After about age 15 years seems to be the inflection point, and from there renal cell carcinoma becomes the dominant type of tumor. Wilms tumor can occur at an older age, but it's much less likely to do so, and renal cell carcinoma becomes the predominant type of tumor that you would run into in young adults and adults, for example. We know that among children less than 18 years of age specifically, there's about a 2 to 6% risk of renal cell carcinoma or translocation carcinoma overall. And overall, there's about a 2 to 1 female to male ratio for those tumors. It's important to note that pediatric renal cell carcinoma is not the same thing as adult renal cell carcinoma. Not only is the tumor biology dependent, but also the clinical behavior will actually be very different as well. The survival of these types of tumors is highly dependent upon both age and stage of the tumor. And interestingly, renal cell carcinoma in children as in adults generally tends to be not very responsive to chemotherapy or radiation therapy. There are, however, some new trials that have just been approved looking at what we call the newer biological types of treatments, sunitinib, those types of things, which actually can be quite effective at treating these tumors. The 5-year survival among children with translocation carcinoma ranges between 50 and 87%, so a fairly wide range. What's interesting about this is that we know that these are actually predisposed to occur after receiving cytotoxic chemotherapy. In fact, the initial reports of translocation carcinomas primarily came in children who had previously been treated for neuroblastoma or ALL. And as it just so happens, neuroblastoma is the most common solid malignancy in children. ALL is the most common hematopoietic malignancy in children. And as a result, because those are the most common, that's why we saw them more commonly in those. Since then, we've gone on to realize that any child who's received cytotoxic chemotherapy can develop one of these tumors long term. They tend to be more common, at least we think at this point, in topoisomerase inhibitors such as etoposide or the irinotecan family of, or topotecan family of agents, as well as in alkylating agents such as cyclophosphamide or ifosfamide. These are universally associated with a translocation, hence the name translocation carcinoma, and these generally tend to be at the XP11 or a translocation of chromosome 6 or chromosome 11 type of a translocation anomaly. Non-translocation renal cell carcinoma can also occur, is by far less frequent, but it can certainly occur. And in general, if one doesn't have a translocation anomaly present in a renal cell carcinoma in a child, you want to start thinking about a familial syndrome in those child. These are very rare, but they certainly can occur. The most common of them is von Hippel-Lindau, which is very famously associated with a chromosome 3p microdeletion, which results in loss of the VHL gene. Tuberous sclerosis is another tumor, is another familial syndrome that can predispose to renal cell carcinoma formation. Birt-Hogg-Dubé can certainly do that, and as well we have more rare variants such as familial hereditary papillary renal cell carcinoma syndrome, and as well hereditary leiomyomatosis and renal cell carcinoma syndromes as well. Those are a bit of a mouthful to say, though. A quick word on translocation carcinoma and how we chose to manage this particular child. Partial versus radical nephrectomy is ultimately one of the things that we do need to consider in renal cell carcinoma. And again, as I mentioned before, in adults with renal cell carcinoma, partial nephrectomy is a very well indicated and very well supported type of modality for those. Really, the ultimate choice between a partial or radical nephrectomy is primarily dictated by tumor size and also the complexity of the removal. Below 7 to 10 centimeters in size, partial nephrectomy, generally speaking, tends to be the more common type of approach to these tumors. But again, that will vary somewhat based upon the location of the tumor. The location of the tumor is directly in the middle of the kidney, for example, and that's going to make reconstruction of the kidney potentially problematic. Then it may not be a good idea to perform a partial nephrectomy. We may need to do a radical nephrectomy instead. A secondary question here is, do we perform a laparoscopic nephrectomy or an open nephrectomy in these children and young adults? Which brings up another controversy altogether. So we do know that from the very few number of series that are out there comparing laparoscopic and open radical nephrectomy in children, that there tend to be good results. Now, those are likely to be highly selected patients, but nonetheless, we do have good data to support the use of this. However, when this has been examined in the group protocols, such as the Children's Oncology Group or the SIOP protocols in Europe, these tend to be neutral to negative to the use of laparoscopic nephrectomy. And again, this raises the question of, is this just simply that the centers that are doing this are doing an extremely good job of picking the right children on whom to do this? The possible benefits of laparoscopic surgery are a quicker recovery, lower overall total post-surgical pain, and better cosmesis as well, a better cosmetic outcome can be important here. The possible harms, as I mentioned before, this is a new technology, this is a very steep learning curve, and we're dealing with a very relatively marginal benefit in a tiny working space, particularly among infants, where these tumors can be quite big and the belly itself is not very large at all. And so we have a very small working space trying to do a very delicate surgery inside of that space, and that can be a challenge. The cosmetic benefit bears a bit of further discussion. This is a typical type of appearance that you would expect to see from open surgeries. One, the upper example there is a flank incision. Again, not typically preferred for Wilms tumor, but it can be used in times. The second is a transabdominal scar that again can be used for children. And these are very big scars that will obviously leave a mark for the rest of that child's life. Standard laparoscopic scars are actually going to be a good bit smaller, and you can see here there's a significant benefit to these. Now, I should mention that these are both in children in whom we've done benign surgery. In the case of a renal tumor, we would actually need to make one of those smaller, lower incisions a bit larger in order to account for the fact that we have to get the entire kidney or the entire tumor specimen out in one piece so that the pathologist can actually take a good look at it. What I'm showing you here is basically two children who have undergone a benign surgery with laparoscopy in order to give you an idea for kind of what the potential is. There's also a possibility for what's called a hidden incision surgery, and this is typically something that we use using a robotic technique. It was actually developed by a gentleman by the name of Dr. Patricio Gargoyo, now at Texas Children's Hospital. And the idea here is to shift our incisions down a little bit so that in a closed child there is no visible incision. So one working port is hidden inside of the belly button. The camera port is hidden just above the pubic bone, and the other incision is hidden, again, below the belt line, just off the intersuperior iliac spine. In very, very highly selected patients, we can also do something called single port surgery. The idea here is to make a slightly larger incision within the belly button so that, again, there are no visible incisions that are readily detectable to the eye. So, my last patient is a 17-year-old boy who recently came in to see me with a new development of abdominal pain. On review of systems and talking to him a bit more, he actually noted that over the past year he's had about a 15-pound weight loss, which was unintentional. Again, vital signs are fairly normal, but on abdominal exam, he's non-tender, he's non-distended, but there is again a palpable midline mass in the middle of his belly, just above his belly button. And on genitourinary exam, when I took a feel of his testicles, I was able to feel a very small nodule on the right testicle. We then at that point went ahead and drew some labs based upon those, and any time that one feels a nodule in the testicle, the first thing that you want to do is perform what's called tumor markers, or check some labs that will tell us how likely it is that, this young gentleman has testicular cancer. In this case, his labs were very, very elevated with an LDH, or a lactate dehydrogenase, of about 2,000. Normally that should be less than about 200. Beta HCG normally is going to be undetectable or less than 1. In his case, it was 246. And an alpha fetoprotein, or AFP level, which again is normally going to be single digits, in his case was at 35,000. So very, very elevated. We then proceeded with the standard imaging workup, which begins with an ultrasound of the testicle. And although it's a little bit difficult to see here, what you can tell is that there's a large cystic mass right smack in the middle of his right testicle. Here's another image where we can see actually a second mass also present again within the right testicle. And this is actually the one that I was able to feel on exam. This is a very small, firm nodule just on the side of the testicle. So standard management is to then proceed with further imaging, typically with a CAT scan of the chest, abdomen, and pelvis. And what you can see here is 3 very large nodules, very large tumors present within the liver. And as we get on a little bit further, a very large mass present within what we call the retroperitoneum, the back side of the abdominal cavity. And this is all highly worrisome for lymphatic spread or tumor spread of that testicular cancer. So here's another what we call a coronal view, where you can see at the same time multiple masses present throughout the liver and a very large mass present in the back of his belly as well, just in front of the spine. So we then actually proceeded with what's called a radical orchiectomy, removal of that right testicle, and the diagnosis came back as what we call a non-seminomatous germ cell tumor. This is a mix of 2 different types of tumors. And in testis tumors, this is actually the most common occurrence. A non-seminomatous tumor is typically going to be a mix of several different types of testicular tumors all together. And luckily, the treatment for this is actually very well described. Once a young man has had the initial tumor removed, we then proceed with 4 cycles of chemotherapy, bleomycin etoposide and cisplatin typically. And at that point then we go through and attempt to remove any remaining tumor that is present. If you haven't had at least 90% reduction in the tumor size, then the next step is to make sure that we get that 90% reduction. If chemotherapy couldn't get them there, then we have to cross the finish line by surgery means. We then proceed with what's called a retroperitoneal lymph node dissection with a concurrent resection of those liver tumors as well. And here's a brief glance at the inside of his belly for kind of what things look like afterwards. The bottom really big vessel that you can see there on the right is his aorta. That's the big artery that runs down the back. On the left, or excuse me, on the top side there, you can see what's called the vena cava. That's the really big vein that runs down the back as well. And in between, you can see what's called the spinous ligaments, or the back covering of the spinal column. And in this case, what you want to do with these types of tumors is take out every last cell that is there in order to make sure there's nothing left that can come back and bother this guy further on in life. So a quick word about testicular tumors in general. These really come down to, has the patient hit puberty or not? Before puberty, in the pediatric age groups, the most common types of tumor are going to be a teratoma, which is a benign tumor, a yolk sac tumor, which is unfortunately a malignant tumor, or a stromal tumor or a cyst. All of these tumors need to be removed surgically, but in only one situation do you actually need to remove the entire testicle. If this is a yolk sac or a malignant tumor, you do want to remove the entire testicle to make sure you get all that cancer out. In the case of those benign tumors, however, you actually want to make sure that you're leaving as much of that testicular parenchyma, or the testicular tissue, behind as possible. In adolescent or post-pubertal children, after puberty, the things change a little bit, and actually germ cell tumors or malignant cancers become much, much more common. That's not to say that benign tumors can't occur, because we do still see teratoma and stromal tumors that can occur, but they're much less common, and therefore the standard of care after puberty is to remove the entire testicle by what's called a radical orchiectomy. The initial management for children with testicular tumors, or for adults with testicular tumors as well for that matter, is to perform a scrotal ultrasound to get a better idea for what we're dealing with, and also, just as importantly, to make sure that the other side is actually perfectly normal as well. We then actually will check tumor markers. As I mentioned, AFP, LDH, and beta HCG are the typical 3 that we start with. And then to perform a partial or radical orchiectomy, one of the 2, depending on primarily on the patient's age and whether or not there are any tumor markers that were elevated. In the setting particularly of an AFP that's elevated in a small child, that would be an indication to proceed with a radical orchiectomy because a yolk sac tumor would be much more common in that situation. But in general, in prepubertal boys with negative tumor markers, testis-sparing surgeries or tissue-preserving surgery is really the standard of care for those children nowadays. So in general, in summary, genitourinary tumors, highly team-driven and multidisciplinary care, such as we give here at Duke, is really the mandatory standard of care for how, in the modern era, you should be treating these types of tumors. Luckily, and on a more very positive note, in general, children are going to have an excellent prognosis for most of these tumors. And we do know from good data that's out there that high-volume centers, generally speaking, are going to have a much better overall outcome and a much better overall prognosis than lower-volume centers, which really, again, I think speaks to the impact and the importance of that team approach. There's, in modern era, kind of an emphasis on minimizing treatment burden while maximizing survival, and that's why you're seeing these controversies nowadays with increased use of prognostic biomarkers, increased use of partial nephrectomy or orchiectomy instead of radical nephrectomy or orchiectomy, and also increased use of laparoscopic surgeries or robotic surgeries in order to basically make sure that we are treating the tumor as aggressively as we need to be doing, but not treating it any more aggressively so that we're not punishing the child for having bad luck of developing a tumor, but rather helping them in order to get out that tumor and make them as healthy as quickly as we can, as possible as we can. So if you have any questions, please don't hesitate to contact me. There's some further reading that can be useful, and I appreciate your attention. Thank you.